that if you get confused, please ask questions because somebody else has the same questions. And it's totally fine. Like the endocrine system doesn't have to go super quickly. I don't really mind slowing down and making sure that you get it. We're going to start with the thyroid gland. Remember that what we have been doing is this, and what we're ultimately going to do is do the feedback loop of thyroid. We're probably ready for it because we did it on the board, and I'll let you guys guide me through it. Okay, so you guys know the anatomical location of your thyroid, right? Just below your larynx, and it's kind of butterfly shaped right there. Okay, so the thyroid secretes 3 hormones, and this is important, when people say thyroid hormones, they're only talking about the first 2. The other one is always referred to by its name, which is calcitonin, and it is not regulated the same way as the other 2. Okay, so that's important to understand. So the classic thyroid hormones are T3 and T4. Let's review their long names just so that you can understand the value in learning the long names. They are triiodothyronine. And if you break it down, it's not even that hard to spell, right? Triiodothyronine. 3 iodines from the thyroid, and it's an amine. Yeah, that's T3. And T4 is tetraiodothyronine. Yeah? And that's T4, 4 iodines from the thyroid, and it's an amine. The other commonly used name for T4 is thyroxine. Okay, that's really commonly used. Okay, so big picture of what thyroid hormones do, because you could talk about them for half an hour very easily. Both of them are responsible for increasing the metabolic rate in almost all of your cells. So all of your cellular respiration processes, your anabolic and catabolic processes, they increase the metabolic rate in all cells in the body. And they are also incredibly important during development, specifically during brain development. Now, during all development, of course, you're going to need adequate thyroid to support growth and development. But embryonic and fetal development of the brain, you get one shot at that, right? Because after fetal development, your neurons are mostly amitotic. They don't divide any longer. So you get one shot at going through this. So they're absolutely necessary for proper brain development and function. And this is important for those of us who could be pregnant or could be the partner in a pregnancy to know that if you are trying to have a healthy pregnancy, you must assess your thyroid levels. It happens during the very first visit to the doctor. Now, because the fetus gets one shot at putting their nervous system together. Now, I am not saying that you can't have a thyroid problem and have a healthy pregnancy. You can, but you have to treat it. You have to treat the thyroid problem during the pregnancy. Okay, so we'll talk about what happens if that doesn't happen. We'll talk about a disorder in just a second. So thyroid hormone affects almost all of your tissues, especially during growth, but also in adulthood. We'll see what it does if you have abnormal levels of these. So the chemical class of hormones, T3 and T4 are your only lipid-soluble amines that you guys are learning. Iodine is, of course, required for the synthesis of both of these hormones. And I mentioned this before, but let me just reiterate. These 2 hormones are also required for the production of growth hormone, and this is the way that I think about it. Growth is extra, yeah? Do not commit to growth if you can't support your metabolism. So what will happen is if you have inadequate thyroid hormone, for instance, during growth and development, you're also going to have growth problems, right? Because you didn't have the metabolic support for growth. That makes sense? Okay, so you can't commit to growth until you have the metabolism to support it. So thyroid problems will cause growth problems. Okay, so before we get into the clinical connections, I want to have you guys guide me through doing the feedback loop that regulates T3 and T4. Okay, so I did it once for you. I want you guys to guide me through it, and then we're going to mess with it. We're going to break it with a couple of disorders. Ready? Okay, so if I were ultimately trying to regulate the secretion of T3 and T4, first question is, what organ do I start with? Yeah, I start with the hypothalamus. And the hypothalamus secretes what relevant hormone? TRH. Okay. TRH goes where? Anterior pituitary. Did you see? Not one of you guys said thyroid. That's just one freaking lecture. Look how brilliant you are. Okay. And then the anterior pituitary secretes what hormone? TSH. And then TSH goes where? Thyroid. And the thyroid responds by secreting what? T3 and T4. Note to self, your textbook goes into excruciating detail about the difference between T3 and T4. And one of them is in higher concentration and one of them is more effective. But for right now, we don't need that information. I don't ever test you on it because there's a hell of a lot more we have to do than just the biochemistry of these two hormones. Okay, now, how does your body know when you have enough T3 and T4? What's the feedback loop? Where does it go? Hypothalamus, yeah. Yeah, long loop. Okay, so remind me, and then we'll start breaking it. What is special about these hormones that allow them to go all the way up there? Yeah, they're lipid soluble. Okay, so keep that in mind, and now let's start breaking the thyroid hormones and talking about disorders. You ready? Okay, so first one is what happens if you have a woman with a pregnancy and she has untreated hypothyroidism. She doesn't treat it during the pregnancy. It is pretty tragic, honestly. It's called congenital hypothyroidism. It used to be called cretinism, but that was a little insensitive, so we don't call it that. What it will cause is permanent developmental delays. It also causes short stature if the baby lives. Quite often, these babies will die in infancy. They are going to have severe developmental delays. So I want to show you, here's a baby with congenital hypothyroidism. So there's a couple of things that I want you to notice. First off, the tongue is protruding, the abdomen is protruding, and he even has a little bit of a hernia right here. So what happens with congenital hypothyroidism, in addition to the brain developmental problems, it actually causes growth problems, but it impacts growth of bone and cartilage more than it does of soft tissues. So what happens is the soft tissues tend to grow a little faster and they protrude, right? Does that make sense? So this is congenital hypothyroidism. They used to call it cretinism. Why do you not see a lot of babies with this? Well, because it's treatable. If you just assess your thyroid level and you had hypothyroidism, you can treat it. And of course, most of us in this country have the access to medical care. Not necessarily can we afford it, but we have access to medical care in this country. But historically speaking, cretinism, sometimes they would live. You are going to have people with severe developmental delays. Sometimes they were institutionalized. As they got a little older, sometimes they would develop a goiter if they lived past that. And notice the short stature on both of these. So this is a historical drawing of actual cretinism. In addition, lots of women will miscarry early in pregnancy if they have untreated hypothyroidism. So you don't see the babies as frequently as you imagine. A lot of times they'll get institutionalized and then sometimes they don't live past infancy. So this is a severe developmental disorder. Okay, now, do people get thyroid disorders in adulthood? Well, yeah, I bet you know somebody who has a thyroid disorder in adulthood. They're not at all uncommon, especially since both of the two common forms of thyroid disorders are autoimmune. So I don't know why she looks so damn sassy with both of these problems going on, but she does. Okay, so hypo and hyperthyroidism. So before we get into the symptoms, I want to see if you guys can either tell me some of the symptoms or hypothesize some of the symptoms. So let's do hypothyroidism first in an adult. Okay, it is usually autoimmune. Your immune system is a bastard and likes to attack your thyroid gland more frequently than you would imagine. If you have a certain percentage of the symptoms associated with hypothyroidism, you can get diagnosed with Hashimoto's disease. Okay? Now, there's a whole bunch of symptoms. If you only have a few, you have hypothyroidism, but you don't have Hashimoto's. Right? Does that make sense? So every person who has Hashimoto's has hypothyroid, but not every person who has hypothyroid has Hashimoto's. Does that make sense? And as far as the number of symptoms, it changes all the damn time as they add a new symptom, right? Which ones you have to have a certain percentage of them. So what do you think some of the symptoms of adult hypothyroidism are?
Fatigue.
What? Fatigue, yes. What else? Weight gain, yeah.
But then on the lab manual, it says that decrease the appetite.
Oh, a lot of times it does. But it decreases your metabolism. So you don't have to eat more to get fat if your metabolism is slowed, right? That is the unfortunate part of being in your 30s and 40s. You're like, I literally am eating the same damn thing that I ate when I'm 20. I don't know how the hell I gained 5 pounds by eating a 1 pound bag of Oreos. That should not be possible. That's a conservation of mass issue. Okay. But it does. Okay. So So you get weight gain, you get fatigue. Anything else? Does anyone know? Is it just physical fatigue or is it also mental fatigue? How about thermoregulation? Heat or cold intolerance? Yeah, a lot of times you get really cold. You have trouble warming up. So hypothyroidism, here are some of the symptoms. Weight gain is the one that most people associated with it, but it also causes constipation and brittle nails. And because of the lack of supporting of your metabolism, in men and women, you can get infertility. But this disorder, like all autoimmune disorders, is more common in women. Depression, mental and physical fatigue, you have trouble heating up, and then both of them cause hair disturbances, and then both of them can be associated with goiters. Do you guys know what a goiter is? Okay, so let's look at a couple of goiters. So here's a relatively normal looking goiter, okay? And a goiter is an increase in size of the thyroid gland that's usually visible with the naked eye. They can be really, really subtle, so you don't always see them. So a goiter can either be a response to hypothyroidism, like if your thyroid is underproducing, then this is epithelial tissue, right? Glandular tissue is epithelium. You can make it go through cell division, it'll get bigger because it's trying to compensate for what occurs, right? But it can also be, just so you know, a goiter can also be associated with hyperthyroidism because it can be the cause of the hyperthyroidism. Like if you had a benign tumor, yeah, it could be the cause. So it's associated with thyroid disorders, hypo or hyper. Okay, is that good? All right, so Hashimoto's disease is generally autoimmune. Your immune system usually starts attacking the thyroid, but note to self, couldn't hypothyroidism occur here, here, or here? Yeah, it could, right? Because the whole thing is involved. The most common place and the easiest to treat is when it occurs here, but it can be a pituitary problem. Hypothyroidism. If you have a pituitary problem, you are very likely to have a T3, T4 problem. Does that make sense to you guys? Okay, and you wouldn't necessarily treat it at the same time. Sometimes they treat this with TSH and T3 or TSH and T4 or Synthroid or whatever they want to call it. Okay, so let's talk about that briefly. You probably know someone with a thyroid disorder, probably know someone with hypothyroidism. It's not at all uncommon in women in their 30s and 40s and 50s. What was the treatment? Yeah, and what kind of medication? Yeah, they add some kind of, like thyroxine is T4, right? And they can add a different, or Synthroid or something. And usually oral supplements, because it's lipid soluble, so you can do oral supplements, right? If it were not lipid soluble, if it were peptide based, you would actually have to do something different, something big, more of an intervention, like an injection. Does that make sense to you guys? Okay, so now, do you think that taking it orally, you are going to get the same regulatory feedback as quickly? So if you wanted your thyroid level and your metabolism to do this, but instead of doing this on a regular basis, you are only assessing this and changing the dosage once every 6 weeks, do you think that you are going to stay in the range as readily? No, you're not. Right? So one of the things that people with thyroid disorders run into is the problem of, I'm assessing my thyroid level, I'm choosing a treatment level for the medication, right? I'm trying that for X amount of time. And guess what? Oh, that was too much, and now I've switched into hyperthyroidism, right? Oh, that was too little, and now I'm hypo again. And sometimes it can take months or years to get the level right, and then your metabolism changes, and then you have to do it again. So this takes some input. It takes some professionals and some really close monitoring. Okay, so hyperthyroidism, before I tell you, what do you think some of the symptoms of adult hyperthyroidism are? Weight loss is one of them. And that sounds pleasant, but the rest of it, I promise you, is not. What? Sweating, trouble with thermoregulation, you can't cool down. How do you think you'll sleep if your metabolism never goes down? Sleeplessness, anxiety, irritability also changes. So you also get hair loss, heartbeat increased pretty dramatically, actually. Infertility can also result from this, nervousness, weight loss. You get the squirts a whole bunch. And you really have a lot of trouble cooling down. So this is hyperthyroidism. There's a whole suite of symptoms. This isn't even all of them because you can tell this picture is kind of old. I just thought it was nice that it had both of them in the same place. There's a suite of symptoms associated with hyperthyroidism. If you have X number of those symptoms, you can be diagnosed with Graves' disease. So the same kind of thing occurs. Not everybody with hyperthyroidism has Graves' disease, but everyone with Graves' disease has hyperthyroidism. Does that make sense? Okay, so some of the new symptoms that were not associated before that are associated with hyperthyroidism, or one of them, is exophthalmos. And exophthalmos is, for some reason with hyperthyroidism, and I don't even know if it's known. If it is, I don't know it. You lose weight almost everywhere, but you deposit fat behind your eyes and your orbit, and it pushes your eyes out. It's called exophthalmos. It can get so bad that you can't even close your eyes. So this is exophthalmos. That's associated with hyperthyroidism. This is a woman pre and post-treatment, exophthalmos to post-treatment. Do you see the difference there? Okay, and then a goiter can also be associated with hyperthyroidism. So you've got this relatively minor goiter. Now again, the way that works is if I had a benign tumor here, it could cause hypersecretion, right? So with hyperthyroid, the goiter is often the cause, right? With hypothyroid, the goiter is often the response, okay? You can have massive goiters too. Here's a huge one. This huge goiter. Now, this is usually because of a dietary deficiency in iodine. And if this woman had known about this long before, it would have been really, really easy to treat. They can treat it now just by adding the iodine back. So if you don't have enough iodine, your thyroid's going to go, I still can't make enough thyroid. I still can't make enough thyroid, and continue to increase in size. Add iodine to the diet, and then it goes, oh, I can make enough. Now, with this woman, she lived in an area where iodine is not readily available. And that typically happens in areas of high elevation, lots of snowpack that then melts because iodine is water soluble and it just gets carried down the mountain. So the people who are living like in the high portions of the Andes and the upper portions of Africa and Asia and really high villages without access to iodine supplementation would sometimes get iodine deficiency goiters associated with it and all of the others. But it's really easy to treat. Now, we don't get it here in the United States. First of all, we don't all live at super high elevation, but even those of us who do, if you ate a lot of fish, you wouldn't have an iodine deficiency because it's primarily in seafood and a little less in freshwater, but still there, okay? But how do we get a lot of our iodine since nobody in Utah eats fish? Yeah, we iodize our salt to prevent these disorders. That's why it's iodized, all right? That makes sense? And we have no problem eating salt. No problem eating salt. Yeah. Go ahead.
Somebody who worked at Whole Foods actually got one because she didn't have enough iodine because everyone eats sea salt.
Yeah.
That's like a problem.
And so she doesn't like eat. She's like vegan too, so she was getting a lot.
Oh, interesting. So she was like really tightly controlling her food intake, so she wasn't even probably was eating fast food where you get plenty of iodized salt and only eating sea salt.
Yeah.
Right.
Like Himalayan sea salt has literally made the health community get iodine deficiency.
It's delicious though, right? But you gotta go a little lowbrow sometimes when you get your iodine.
50-50 with iodine salt, you know.
Oh, they do?
They should.
Yeah, they should. But a lot of people are scared of iodine. Like they think it's some kind of poison. Yeah.
They put it there for a reason.
Yeah. Yeah. So that's interesting that actually happened at Whole Foods. Damn hippies.
Yeah.
A little education is a terrible thing. My mom was a hippie, so I can say damn hippie. I was raised by a damn hippie. Okay. So hyperthyroidism, we did it. Okay, I got to show you a weird form of hyperthyroidism. Not usually. The easiest way to think about hyperthyroidism is I have a benign thyroid tumor causing hypersecretion, but there's a really interesting way that you can get hyperthyroidism that's actually autoimmune. Now, it makes more sense to me to think of autoimmune disorders causing hyposecretion, because if you destroy something, it can't secrete it. But this is a weird situation, and it's actually the most common type of hyperthyroidism. But I want to explain it to you, and I want to make sure you get it. So I'm going to ask some questions about it as I go through. The most common form of hyperthyroidism is autoimmune hyperthyroidism, because something weird happens. Generally speaking, this is how this works, but let's break it. What happens with autoimmune hyperthyroidism is I get exposed to some kind of pathogen, nobody knows which one, and I make antibodies. And you guys know that you make antibodies in response to pathogens, right? Do you know what antibodies are? Are they proteins? Are they lipids? Are they carbs? What are they? Yeah, they're proteins. And TSH is also a protein. Okay. So the antibodies are TSH mimics, which we call agonists. They just happen to look enough like TSH that they fit into the receptors on the thyroid and activate the thyroid to cause T3 and T4 secretion. Nobody thinks that this is a purposeful evolutionary thing. It's just, hey, that fits, and it actually causes the activation. So it's a TSH mimic. Now, here's my question to you. How the hell is a doctor going to tell that this is an autoimmune hyperthyroidism versus the other kind, like a tumor related? So I want you to think about the levels of each of these hormones. If I let this continue for a minute. So if I let this continue and the antibodies are stimulating the thyroid, what's going to happen to my levels of T3 and T4? Going to go up. Okay. Now follow me to the next question. Let it go on for a little while before you treat it. What's going to happen to my level of TRH? It's going to go, say it, I'll be supportive, I promise. It's going to go up, down. Negative feedback inhibition, you got it? Do you see that? What's going to happen to my level of TSH? It's going to go down. And then here's the interesting part. So my TSH is low, but my T3 and T4 are really high. My TRH is low. So the doctor looks at this and like, what the heck? How the hell can your T3 and T4 be high when your other two regulating hormones are low? So you can see that something is actually interrupting it right there. Do you see that? Okay. Does that make sense? Okay. And then to confirm that it's autoimmune, all what they would have to do is go check for this antibody. That makes sense? Okay, so last question is, again, like we talked about last time, which do you think is harder to treat? Hypersecretion or a hyposecretion? Which one's harder to treat, hyper or hypo? Hyper. Yeah, because what the hell do you do? Right? Do you take this out? If you take it out, you got a whole bunch of other problems, right? And if you can't take it out, then what do? Well, you hope that a medication exists that is a blocker, right? That actually is going to block the effect, but we don't have those medications for every chemical messenger. They don't exist. They're called antagonists, and sometimes they exist and sometimes they don't. Does that make sense to you guys? Okay, so this is autoimmune hyperthyroidism, okay? And it's actually the most common form of hyperthyroidism. All right, so the question I asked you right here is which hypophysiotropic hormone, because you need to know that word, and which pituitary hormone ultimately controls the secretion of T3 and T4. And this is the answer, right? Which of these is a hypophysiotropic hormone? TRH, yeah. Hypophysiotropic, go hypothalamus to anterior pituitary. Good? Okay. All right. Now, we have to meet another hormone, and the other hormone comes from the thyroid but has nothing to do with this regulatory mechanism. And you need to grasp this one, okay? So the other hormone that comes from the thyroid is always called by its name. It's called calcitonin. I teach it in anatomy. So my anatomy students are probably a little familiar with it. If you didn't have it, it's fine. It's actually relatively easy to understand, okay? So the thyroid also secretes calcitonin, but I'm going to show you the feedback loop, and it's really short, and it doesn't have a damn thing to do with the hypothalamus. You ready? Okay. With the thyroid, it also secretes calcitonin, and the job of calcitonin is to tone down blood calcium. That's how I remember it, but you have to put blood in there because it's not bone. Tone down blood calcium. And primarily it does this, guys. The primary mechanism is by deciding what to pull from the bone versus keep in the bone. Do you guys know that your bone is basically a calcium savings bank? Yeah? Whenever you have excess, you deposit it in your bone. Whenever you have a deficiency, you remove it from your bone. Okay, so I want to look at the feedback mechanism for calcitonin. So it's going to target bone tissue to increase calcium storage. It's basically going to trigger osteoclast activity to lower. And so you guys tell me, as I start this feedback loop, if its job is to tone down blood calcium, it is going to be released in response to what? High or low blood plasma calcium levels? High. Got it? Okay, so let's play with it. You ready? Okay. High blood plasma calcium. will be detected where? It's going to be detected where? Nope. Just thyroid, right? Skip the whole damn thing, just go straight to the thyroid. It's different cells in the thyroid than those. And you can learn the name of the cells if you want to, but I don't think you do. And in response, the thyroid is going to secrete what? In response to high levels of blood plasma calcium, it's going to secrete calcitonin. Calcitonin's target is going to be the place that I can store that excess blood calcium, which is where? Bone. But specifically, I want to tell you what it does. It goes to osteoclast and bone. Do you guys remember osteoclast and osteoblast from anatomy? Okay. Osteoclasts are bone matrix destroyers, and osteoblasts are bone matrix builders. And what I have to do is, if I want my bone mass to stay constant, then they stay constant, right? But if I, for instance, want to decrease my bone mass or increase my blood calcium, then I could do it by manipulating osteoclast or osteoblast. With this one, it goes to osteoclast, and what it does is it decreases osteoclast activity. So think about that. If they were even, and you decreased osteoclast activity, relatively, you would have more osteoblast activity and make more deposits. Yes? Into your bone mass. That make sense? Okay? All right, so decrease osteoclast activity in bone. The net effect would do what to your blood plasma calcium levels? Yeah. What do you think the feedback mechanism is? Any idea? Yeah, and what feeds that? It's just the calcium level, right? Basically, I just have a new bit of data, and then when the blood plasma calcium is low enough, it no longer triggers calcitonin release from the thyroid. Does that make sense? It's going to feed back as new data. It feeds back to the thyroid, but it's new data to the thyroid. Does that make sense? Got it? Okay. So, this is one of the ways to regulate the calcium. I'm about to show you the other one. So, the job of calcitonin is to tone down blood calcium. So, we'll talk about when you would release this in just a second. So, note to self, please note that calcitonin has nothing to do with this regulatory mechanism. This is for regulating T3 and T4. Even though they both come from the thyroid, everybody tries to do this on the test. I don't know why. I asked them for a regulatory mechanism that is an ion feeding back. And they're like, oh, calcitonin, start at the hypothalamus, go to the anterior pituitary, make some calcitonin. No, it's not anything to do with calcitonin. Okay, so let's practice the other one that does the opposite of this. So calcitonin, by the way, is a peptide too. Ends in IN. So you should be able to fill out the calcitonin table. Oh, I have a question for you. Okay, before we move on to the next one. What if I told you that even though you don't have to memorize it, I want you to be able to think through. If I told you that calcitonin, in addition to targeting the bone, also has two extra targets. I don't want you to memorize what it does there. I want you to think it through. The two extra targets are going to be the kidney and the small intestine, the lining of the small intestine. Okay. If you look at the functionality, do you see that you probably don't have to memorize what it does, for instance, at the kidney? So what's the function of calcitonin? To do what? Tone down blood calcium. Okay. So we know what it does with bone, right? It makes you deposit more of it into the bone. What is something consistent that you could do with the kidney? Say it. Excrete more calcium into your pee, right? What is something consistent that you could do with the intestine? Increase or decrease absorption? Decrease absorption, right? So again, what I'm telling you is that quite often with the endocrine system, you memorize the functionality and one major target, but then you can always think through, right, the next targets. Does that make sense? So couldn't you think that through with a little bit of practice? You probably could. Okay, so what do you have to memorize? Osteoclast and bone. What would I ask a smart A and high B student to do? Think through what it would do at another target. Good? Okay, so let's do the opposite example. And the opposite example is coming from a new gland, which is the parathyroid gland. Where's the parathyroid gland? Parathyroid gland is on the back of the thyroid, so this is a posterior view. It looks like two little sets of nipples on the back of the thyroid. And they didn't used to know that it was a separate gland and was separately regulated, so every time people had thyroid surgery, they would accidentally take those out. And I thought that that was over, but then one of our lab instructors who had a thyroid cancer, they accidentally took out her parathyroid glands on accident. And so now she has parathyroid and thyroid problems. So that's a problem. She is perfectly healthy now, with the exception of the fact that there's a whole suite of medication that she has to take. Okay, so the parathyroid glands are relatively easy because they only secrete one hormone, and it's called parathyroid hormone. Thank you. Okay, so parathyroid hormone, pretty much, it targets the bone and also the kidney to increase circulating blood plasma calcium levels. Good? Increase calcium levels. It also does phosphate. We won't worry about its phosphate activity very much today. So before we go any further, that means that this hormone's action directly opposes the action of what hormone from what gland? Calcitonin from the thyroid gland. Got it. Good? Okay. So PTH, if its job is to increase circulating blood plasma calcium levels, it would be released in response to what? Low. Okay, so let's do it. You ready? So it's pretty much just like this story. Okay, so you would start out with the trigger would be low blood plasma calcium. And where would you detect it? Nope. Parathyroid. So both of them are responding. They respond to two different levels. Parathyroid. In response to low blood plasma calcium, you would do what? Secrete what? What's the only hormone from the parathyroid? PTH. Okay. PTH, primary target is the same cells in bone. So this time, instead of me telling you, I want you to think through it. It goes to osteoclasts in bone, and what is it going to do to them? It's going to increase their activity, yes? Yeah? And what's that going to do to your blood plasma calcium levels? It's going to increase osteoclast activity, dump it into the bloodstream, dump the calcium into the bloodstream, increase your blood plasma calcium. Yeah? What do you think the feedback mechanism is, guys? Yeah, just feed this new level back in as your new calcium level, right? Does that make sense? And what that would do is if the calcium level is high enough, it doesn't trigger the parathyroid. Okay, so let's think about what happens with a healthy person over the course of a day. Probably none of you have PTH and calcitonin problems. So let's talk about what would occur with a normal person over the course of a day. So we carefully regulate calcium. So let's say that's the range that we want over time. So let's say I have a meal and I eat some broccoli and a milkshake, right? Then I'm going to need to bring it back down. I'm going to need to bring it back up. So if I have a meal and eat broccoli and a milkshake, what do I release? What am I going to release? I'm going to release calcitonin, yes? Okay, good. And then my blood plasma calcium level goes down far enough and I haven't eaten anything. What do I release? PTH. Yeah? And this just goes on over time to keep your blood plasma calcium level normal. And why the hell do you work so hard on your calcium? Because again, remember, calcium we will see is needed for nervous system transmission. It's needed for blood clotting. It's needed for cardiac muscle contraction. So you have to really, really tightly regulate your blood calcium level. Everybody good with that? Any questions? Okay. No? I don't believe you. I don't believe there's no questions. You sure? Okay. I want one question and then we'll move on. One question. You just got it? You're just like totally golden? Go ahead, thank you. You're my favorite today.
That lady that got her parathyroid
Mm-hmm.
glands cut off,
Mm-hmm.
she no longer could release PTH.
Yeah, she could no longer release PTH, and her blood calcium couldn't be regulated up.
Does she regulate it herself?
She has to take medication to regulate it now. Every day. Yeah.
Okay.
She has to regulate both of them because it was a thyroid problem, and then they accidentally took off her parathyroid.
How do you do that on accident?
Oh no, what the hell? I thought they knew what they were doing. You would think, like, I don't know, maybe it was because it was cancerous and it was all like, all in. Go ahead.
Are there like side effects? Like you were saying, you can't necessarily regulate it perfectly the whole time with the medication. So that like you might have, I don't know, your bone health maybe is at risk. Or, like,
Totally.
osteoporosis risk.
So you can have those impacts. You can have potential for osteoporosis or potential for actually having too much calcium in your bloodstream, which will cause kidney stones and things like that, right? And then if you take in excessive amounts of any hormone that interacts with a receptor, you have the possibility of downregulation. Then that makes it harder to get your levels back right. So does that make sense? If you downregulate it and you're like, oh, that was too much, then you try to say, oh, I'm going to pull off, but you've also downregulated your receptor. So it takes a hell of a lot of trial and error to get your levels right. So basically, the message that I would like to put forth is don't jack with your endocrine system if you don't have to, because it's pretty finicky, right? Go ahead.
Was calcium also responsible for holding the sodium needs close?
Yeah, it is. So it can cause the hypokalemia, which leads to random depolarizations and muscle twitches and all that kind of stuff. So these two really tightly regulated. Good? Okay. All right. So you guys ready to move on to the adrenal glands? Okay. So let me introduce you to your adrenal glands. You know where they are, right? Yeah? Top of the kidneys, yeah? Here's what they look like, with the exception of the fact that this person did not know anatomy very well, because they ain't nowhere near that big. I'll tell you why they look like that. Okay, when you are talking about adrenal glands in physiology, you have to specify, because the cortex functions entirely differently than the medulla. So you have to specify whether you're talking about the adrenal cortex or the adrenal medulla. And anytime, guys, that you have a cortex and a medulla, where's the cortex with reference to medulla? Superficial, right? Right? It's outside, okay? So the cortex is going to be out here. We'll talk about it first, and we'll talk about the medulla. Probably won't get to that next time. Note to self, interesting little historical perspective on why the hell this adrenal gland is so big in this picture. You don't really care about this, and you won't be tested, but I think it's really interesting. Because when we first started doing cadaver dissections from humans, all the way back into the Victorian ages and all the way back to like Pliny the Elder and all the way back to Greek time, the peoples whose bodies we dissected were primarily people who were indigent, who were incarcerated, who were poverty-stricken. It didn't happen to middle and upper class people. That's not true now. Now our cadaver donors, our body donors, and I am one, are usually middle and upper class, and quite often they're educators or professors or people who have benefited. But historically speaking, they were people who had kind of a rough life. And the adrenal gland, what we will see, is really dramatically related to stress. But you have to broaden your definition of stress to include disease, starvation, injury, all of those kinds of things, and also mental and physical stresses. So when they first started doing it, and they started doing anatomical drawings, they thought that the adrenal gland size was large by default. And when they first started getting cadavers from different classes of people, they thought that they had shrunken adrenal glands. And for some reason, the phys textbooks still have not gotten the message that that's not actually what they look like. But I think it's kind of funny. That's like a little historical like anachronism right there in the textbook. Anyway, your adrenal glands ain't that big, right? Have you guys seen the adrenal glands in the cadavers? They're like little bitty things. Okay, so let's talk about your adrenal glands. We're going to do the cortex first. And before we get into the specifics of the hormones, I have to teach you the naming convention for adrenal cortex hormones, because I didn't understand it, and it made learning these really hard for me. So I don't want it to be as hard for you. I also had a really crappy physiology teacher. Okay, so the adrenal cortex hormones are all steroids. Somebody remind me what I mean when I say steroids. Lipid soluble, derived from cholesterol, right? Yeah? Okay. So collectively, we call all of the hormones that are from the adrenal cortex corticosteroids. Good? They're all corticosteroids. And that specifically means steroids from the adrenal cortex. Good? Okay. But there are 3 subcategories of corticosteroids that regulate salt, sugar, and sex. Okay? And I'm going to tell you the names of each of them, and then you're going to match them to what they regulate. You ready? Okay. So collectively, they regulate salt, sugar, and sex. Okay. The first ones I'm going to call the mineral corticoids. What do they regulate? Yeah, they regulate salt. And then the second ones I'm going to call the glucocorticoids. What do those regulate? Sugar, yeah? And then this will be hard for you. These are the gonatocorticoids. What do those regulate? Yep, salt, sugar, sex. Okay, and then for each of these, you are going to have at least one hormone. So please note what that means with the adrenal cortex. You have to know a little bit more about the terminology. You have to know that collectively all of them are considered corticosteroids, and then when I give you a specific example, you need to match it to a mineral, a gluco, or a gonado. And why am I making you do this? Because they actually refer to them that way clinically. They'll talk about the glucocorticoids as a group, right? Okay, and you need to know what the hell you're talking about with those. So I don't make you memorize very many of each one of them. It's 2 max and 1 for one of them. Everybody good? Okay, so we're talking about the adrenal cortex and these hormones right here. So let's do the first one, the mineral corticoid. This one I'm only going to have you memorize one of. We're going to see it in 3 different body systems. So if you can get it down now, it'd be great. So you only learn one, and it's called aldosterone. Okay, so listen carefully. I'm going to try to explain what aldosterone does for you. Okay, so what aldosterone does, it's the most common mineral corticoid, and it targets primarily the kidney. And here's what it does at the kidney. You ready? So at the kidney, you are going to have exchange, can we agree, between blood and urine. Isn't that what happens at the kidney? Okay. What aldosterone does is forces you to retain sodium, reabsorb sodium, and excrete potassium. Okay. Now I know that that doesn't mean a whole hell of a lot now, but let's think about why on earth we would end up talking about this with the cardiovascular system. Because if you retain sodium, what does it do to your blood pressure? It's going to increase it. So if you had too much aldosterone, your blood pressure would be too high. If you had too little, your blood pressure would be too low. If you had too much aldosterone, you might end up with hypokalemia. Yeah? That makes sense? So it impacts the cardiovascular system via the urinary system. So we are going to talk about this hormone here, cardiovascular, and then again in urinary. So if you can get it down now, your life will be a little easier. Good? Okay. So, and I don't actually hold you responsible for the regulatory mechanism for this one, the feedback loop, yet, because it's kind of complicated. So I'm going to wait until we do urinary system to show that one to you. So you don't have to do the feedback loop for aldosterone. Okay. Glucocorticoids. Glucocorticoids are next. I could actually spend all damn day talking about glucocorticoids. I find them really interesting, and it took me a really long time to organize the knowledge about them. So I'm going to try to organize it for you guys in a way that's relevant and meaningful. There are 2 of them that I want you to know that you're going to run into. They're very similar to one another, and they are cortisol and corticosterone. And they're really similar to one another, so you don't have to know the difference, so you can lump them together for me. Okay, so let me show you a little bit about them, and then we're going to talk about their functionality, and then if we have time, we're going to do their feedback loop. You ready? Okay, so these guys right here, so look right here. Notice that corticosterone and cortisol are over here. They're sort of the gender neutral, sex neutral steroids. But also please note that whenever you mess with corticosterone, you'll have an aldosterone effect as well, because corticosterone is the precursor to aldosterone. So just keep that in mind for just a second. Okay, so let me just talk big picture about what these are for, and then I'll get into some details. You probably will be a little confused about the glucocorticoids at first, but we're going to talk about them now, and then we're going to talk about them again at the end of this set of notes because they're involved in the stress response. All right, so their major function, their big picture function, is to raise your nutrient levels, specifically but not exclusively glucose. Okay, raise your nutrient levels to keep your brain alive whenever you can't eat or won't eat. So on a regular basis, you are going to use these every single night to keep you alive while you're sleeping. Does that make sense? Because your brain is really specific about the nutrients that it requires, right? But you are not going to be taking in circulating blood glucose for 6 to 8 hours while you're sleeping, right? So how the hell do you keep your brain alive? You keep it alive by doing this. So I want to show you this, and it's not going to be the last time. This picture, for some reason, they took out of your textbook, but I will post it for you and you can print it out, okay? So I just want to look at this side. Don't look at stress yet because that's a whole different ball of wax. I want to talk about how you keep your brain alive when you're sleeping, okay? And this is a little bit simplified, but we'll go back and add to it. So generally speaking, what's going to happen is your hypothalamus is your timekeeper, right? And the circadian rhythms are going to tell the hypothalamus when to secrete CRH. You guys with me so far? And that will tell the anterior pituitary when to secrete ACTH. Everybody good? Then the adrenal cortex will respond by secreting cortisol and also corticosterone, but we're going to just concentrate on cortisol right now. Ready? Okay. Cortisol is going to do anything necessary to make sure that the nutrient levels are adequate to keep your brain alive. Okay, so at the liver, even though it doesn't show it right here, before it does gluconeogenesis, it's going to do glycogenolysis. That makes sense? So dump the stored glycogen first, right? And then if necessary, you'll do gluconeogenesis. Do we do that every night? No, we don't do that every night, but we would if we needed to, right? What if you had the flu and you couldn't eat for 48 hours? Then you would do glycogenolysis and then gluconeogenesis, right? But in addition, it will also depress the glucose uptake of anything that's not your brain. Why? Because the brain is the first among equals. It's like, I like you guys, but I always like me better. So anything else that could eat glucose can either suck it or eat something else, right? And what is the eat something else? Well, if you can burn fatty acids, then why don't you burn adipose while I get all the glucose? Does that make sense? Okay. And then if necessary, you will start to break down your muscle tissue to do gluconeogenesis, right? So as long as cortisol is there, it's really hard to build muscle because you are predisposed to breaking down muscle. Does that make sense to you guys? Okay, so to simplify this, let's look. The major metabolic effect of cortisol is to raise blood glucose and other nutrient levels, but it is a costly hormone. It costs you something. It's a pessimist. It is going to say everything else, reduce your metabolism so that we can keep you alive, right? And then after it stops being released, your metabolism can come back up. So it causes glycogenolysis and then gluconeogenesis if necessary. It will also cause lipolysis. Do you see that this is considered a catabolic steroid, not an anabolic steroid? Yes? And if you secrete this long-term instead of just with circadian rhythms every night, but long-term because of stress, and we'll talk about its stress function, what is it going to do to, for instance, your muscle mass? It's going to decrease your muscle mass. It's going to decrease your metabolism because it's telling everything non-essential to suck it, right? Right? So we're going to talk about its stress response in quite a bit of detail at the end of this set of notes, but I just want to get you the big picture understanding. This is your friend in need hormone. You definitely do not want it to stay at your house for 2 weeks though, right? You're like, you're totally welcome, now please leave, okay? And that makes sense? Okay, so this, in addition, because the immune system is sort of a non-essential system, and I know you don't think of it as non-essential, but it is really, immune system is planning for tomorrow, but if you're really not sure if you're going to live today, then you don't really plan for tomorrow. So if you secrete this stuff long term, it actually suppresses your immune system pretty massively because it decreases glucose uptake for like all of your non-essential tissues. And immune and reproductive are pretty non-essential. So it depresses your immune system. You're more likely to get anything. But you can also use this clinically. Because inflammation is the first step of healing with the immune system. And so clinically, let's say I had a closed head wound, then the swelling alone could kill me, right? So what they can do is they can deliver a massive dose of a cortisol analog, like prednisone, right, to reduce inflammation, because that's what this does, among other things. Now, is that something you want to stay on long term if you can avoid it? Hell no, you don't. Now, sometimes it's necessary to keep you alive, but it's certainly not plan A, because I want you to think about all the things that it would screw up. It's going to cause you to decrease muscle mass. It's going to decrease your metabolism and your other tissues. It's going to eventually, by the way, it's going to eventually screw up your blood pressure and your sodium and your potassium. And also, it makes you batshit crazy. If you stay on prednisone for a long time, it makes you kind of like aggro. Okay, so the stress function we will talk about in quite a bit of detail, because the other trigger besides circadian rhythms that can cause you to release this is stress. But again, a broader definition of stress. It could be that you have a crappy marriage. It could be that you cannot support your life. It could be that you have cancer, right? It could be that you are starving. Any of those things causes the same stress response, and the stress response will cause you to release these hormones. But just think for just a second about the difference between releasing this because of circadian rhythms and releasing this because of chronic stress. If I release this because of circadian rhythms, then what happens is my circadian rhythm causes this to be released, and then as soon as the cortisol level is adequate, it will decrease cortisol secretion ultimately, right? But will that happen if I have the chronic stress of an abusive situation in my household? No, because I continue to put in the input, right? And you continue to secrete cortisol, and you secrete it chronically. Does that make sense? So that's what happens with chronic stress. The chronic stress has a physiologically understandable change in your biochemistry in your body. And we're going to talk about that at the end of this set of notes. Everybody good? Okay, so we'll get back to the stress thing. So it suppresses the immune system. The only other thing that you need to know about it, other couple things that you need to know about it, is that chronic cortisol secretion will actually cause your vessels to be slightly constricted all the time. Not acute cortisol secretion, but chronic. And that'll do what to your blood pressure? Increase your blood pressure. And then other little tidbit is that if you can't support your metabolism by having adequate levels of nutrients when you're sleeping or when you're sick, then you should not commit to growing. So cortisol problems will cause growth problems as well. So what kinds of times other than stress and circadian rhythms is cortisol absolutely necessary for keeping you alive? Well, every night it's necessary for keeping you alive, and you cannot live without it. This is a hormone that must be supplemented if it's hyposecreted. But think about the flu, right? Can't eat for 48 or 72 hours. It's cortisol that keeps you alive. Think about the first trimester of pregnancy, in which a lot of us are yakking our guts up and can't eat anything. How the hell do you stay alive and keep the baby alive, right? It's cortisol secretion. It's also one of the reasons that you gain weight, even though you're not eating during the first trimester of pregnancy. It's like dumping it into your bloodstream and depressing the metabolism of anything that is not you or your little adorable parasite. Right? Go ahead.
So like with people who are, like, my niece got into a really bad car accident.
Mm-hmm.
She went to a coma for a really long time. Is her body just going to be responding by dump a whole bunch of cortisol in there because of, obviously her body's under a lot of stress because
Yes.
of the accident. But then are we going to also supplement that to
Supplement her with cortisol?
Yeah.
They usually don't need to supplement her with cortisol. Her cortisol secretion is probably going to be hypersecreting because of the injury. What they need to do is keep an eye on her blood glucose levels and her lipid levels so that it doesn't get completely screwed up. But one of the things that happens when you come out of the coma, of course, your metabolism is completely jacked up, right? It's going to be. It'll just take a little while to regulate back. She did come out of it, didn't she?
No, she didn't.
Oh, I'm so sorry.
Just a side note on how fast your muscles atrophy. She's a dancer, so she was really a strong girl. And in the hospital bed, you can see all the stretch marks from her muscles deteriorating. Atrophy.
Oh, wow. And how long was this period?
3 months.
Wow. Yeah, you will start eating up your muscles really, really quickly. Because if you think about it, the muscle mass that you have is really extra, right? it's not absolutely necessary for you staying alive, so you'll go for your muscles first, and cortisol will start breaking them down. Again, cortisol is a catabolic steroid, not an anabolic steroid. And it's really important to understand that as if people are on cortisol for a long time, or prednisone or some analog of cortisol, you will start losing your muscle mass at the same time that you start gaining weight, right? Because you depress your metabolism, and you'll also depress your immune system, and you're really predisposed to getting opportunistic infections and those kinds of things. Also cancers associated with cortisol. And we'll talk about that when we talk about stress physiology and what you can predict about the life of my middle class, relatively privileged kid, right? Versus the life of someone who is growing up with deprivation, with potential starvation, with a lot of stress in the household, and how quite often our particular society says, as long as we give you the same opportunities in adulthood, then you should have exactly the same responses to opportunity. But their physiology is different, right? The physiology is like notably different in ways that are measurable. So it's kind of an interesting sort of social application to physiology, which of course you guys know I love. I love any social application to physiology. Okay, cortisol is absolutely necessary for life, as we know, especially during prolonged fasting. Note to self, fasting is kind of an interesting thing. They're finding out all kinds of new information about fasting. Now, I know culturally here in Utah, the LDS religion does it once a month, right, for Fast Sunday. And I know that with Islam, you do it during the month of Ramadan, right? And then sometimes our doctors just make us do it, right? And then one of the things that they're figuring out lately is that fasting causes the release of some hormones and paracrine agents into your body that seem to reduce cellular aging. And so it does seem to be an effective physiological mechanism. And as long as your cortisol is normal, you can stay alive through fasting. So there's some fascinating information now. So we talked before about the whole ketogenic diet. And I think I told you that cardiologists are not fond of the ketogenic diet. Guess who is really, really fond of the intermittent fasting diet? Almost all physiologists and lots of doctors, unless, of course, you have an eating disorder, and then do not do that. So we'll talk about a little bit about the intermittent fasting. Intermittent fasting is like either 2 days a week or a certain number of hours per day fasting. Okay. What?
People at Whole Foods love those too.
Oh, the intermittent fasting? Yeah. So I'm always skeptical about any kind of new diet, especially if it came out of like weight loss instead of out of like physiology. But this one is one I'm going to keep an eye on just to see what happens long term with the long-term studies of it. Okay, so I will see you guys. We're not having a quiz on Thursday because the 8:30 class voted against it, but you are going to have a beastly one on Tuesday. We should finish all the hormones.